normal would be like bright, like a little bit of bright red blood? Like if everything is that
But
reassuring?
sometimes
Or?
it's pretty brisk. I mean, it can be hard sometimes. I mean, if you, like, going back to the paper cut analogy, if you like cut your finger like that, oftentimes it'll bleed pretty briskly, for a little bit until you hold pressure and it stops. So sometimes a normal flap will bleed quite briskly, but as long as it's bright red blood, then I'm not too concerned about that. But then it might be something to just monitor and go back, for the resident to check themselves every hour or a little bit more frequently, just to make sure it's not something that's progressing. Because a lot of times, the goal is to catch things as early as possible, but that also means that you might, in these situations where you're not sure, then you're trying to rule out whether or not it's a progressive perfusion problem. And if you're catching early venous outflow obstruction, meaning like the flap is now bleeding more than it ought to be, then over time that's going to worsen and the flap's going to start getting purple and it's going to start getting blue, and arterial thrombosis that follows that is extremely difficult to salvage at that point, because that means the entire flap has like become static and clotted off. So if they come back and they can just kind of scratch with a needle the cut that we already made there and elicit bleeding from the cut that we already put there. That way you don't have to be like stabbing the flap over and over again with needles, because that ends up causing bruising if the flap's not dead. And then that becomes more difficult to interpret because now you have a bruised flap that may have a perfusion problem. So yeah, so you're just looking for the speed of bleeding. But again, as long as it looks bright red, then, even if it's pretty slow, as long as it's present, and when it's starting to get ischemic, you see this weird like serous component to the blood. Like you might see a tiny little drop of blood, and then there's like this serous fluid that also starts coming out. And that's usually a bad sign.
Is imaging ever helpful? Like if you're not sure, like does CT or ultrasound, or I don't know, is there any like, objective studies that help you decide?
Well, the problem is if there's really a problem, you kind of need to act on it more quickly. So you can't really wait around for like trying to get a CT. I mean, theoretically, I would think like a CT angio, you could look at it at the pedicle. You could do like a duplex ultrasound and look at the pedicle. And I think there are times when we've tried that when we're like, I really don't think this is a true problem, but I just want to like be able to sleep better tonight. But, the classic teaching is like, if you're in doubt, just go back to the OR and just open it up and check, because worst case scenario, you like had an unnecessary take back and you spent like a couple hours, mobilizing the OR and then half an hour to actually like look in the neck and assess the pedicle. The patient's had a little extra anesthesia, but a lot of times they have a trach anyway. So it's like pretty easy to induce anesthesia in them. If they don't, and it's like a difficult airway, then that's that factors into your decision making too, because it's all just like risk benefit analysis. But really, if you have a doubt about the circulation of the flap, then going back to the OR is the gold standard thing to do at that point.